Okay, good evening, everyone. Just going to give a few people a chance to join, get everything set up, be with you in 1 second. Okay, so hello and welcome back to the Mind the Bleep surgical sessions. This week we're doing a session about stomas, quite a short session, but actually I think it will be really useful because stomas are something that I remember as a student I was quite afraid of, and the facts and figures about them are not always obvious. It can be a little intimidating to examine. And so we're going to go through everything you need to know about stomas as a surgical junior on the wards this week. So this is just a quick welcome back to the course. Reminder that it's designed by junior trainees for junior trainees. So we are really looking for your feedback. Any questions, you can always give us an email at our email address for Mind the Bleep. And this week we just got a quick message from our sponsors. So this is CPD Me. They're an easy CPD portfolio building app. They've basically replaced the GMC's app service, creates super easy interface, and we have a special code via Mind Bleep so that if you sign up, it's just £8 for a year, and that's a 50% discount. So they're specifically designed for those who need CPD portfolios with GMC or NMC UK registration numbers. So do sign up to that if that's something you're interested in. This is me again. Hello, I'm academic FY2. Very excited to talk to you this week about stomas. So the key things we're going to be addressing this week are we're gonna do a little bit of anatomy, and we're going to talk about some of the common surgical incisions. We'll go through the abdominal wall, and then we will move on to understanding a little bit more about stomas themselves. So as every week, we'll go through a case, and this week you're the surgical FY1 on take when you get referred a patient, a 75-year-old gentleman with hypokalemia, hyponatremia, hypocalcemia, and hypophosphatemia. And you might be wondering, quite rightly so, why this gentleman with electrolyte abnormalities is being referred to surgeons. Well, he actually has a background of having a Hartmann's procedure for a large bowel obstruction secondary to bowel cancer. And this was 2 years ago. So if we move on to our key surgical questions that we're asking all our surgical patients, we want to check about nausea and vomiting. And this gentleman does have some nausea. He still has it. And actually he had 2 episodes of vomiting last night, projectile vomiting, quite severe. He has this sort of vague abdominal pain which moves around the abdomen, but is sort of nowhere specific at any one time, and it's more just like crampy. His bowel habit is obviously a stoma, and we'll move on to talking about that in a little bit, but he's not jaundiced and he hasn't had any constitutional symptoms. So this week I'm using something called Mentimeter, and it would be great if you guys could go to www.menti.com and use the code here, or you can scan the barcode. And by doing that, we're going to have access to some questions which are here. So I'll just give everyone 1 minute to get onto the presentation on menti.com, and then we'll start going through the questions. Okay, well, people have started answering the questions. Thanks very much. So I'm going to crack on. So, we got lots of things. This is quite exciting for me. This is the first time I've used it. Wow, this is quite cool. Okay, so what is a Hartmann's procedure? You just crack on and answer like you're doing. So just send in your last answers now, and I'm going to hit to show the correct one. Oh, cool. Yes, so well done to those of you who answered left hemicolectomy with end colostomy formation. That is the full name for the, well, I guess it's a sort of slang term, Hartmann's procedure. Okay, so back to the presentation, and we'll keep doing those as we go through. So keep that page up because I'll move it on to the next question later. So right at the start of the presentation, I thought, given we were talking about stomas, we could go through a few surgical words as well that get bandied about, but no one ever really stops and tells you what they actually mean. And then you come to being a surgical FY1, you're sort of like, what does this actually mean? So a stoma is just any artificial hole made into a hollow organ. And that means that it could be an internal stoma, an external stoma. So the ones that we all classically think of, I guess, are ileostomies and colostomies, but you can actually have an internal stoma, something like a gastrojejunectomy, that would still qualify as a stoma. And so moving on to those surgical words I was just alluding to, so ostomy means to make a hole in, whereas otomy is cutting into. Ectomy is taking anything out, so like an appendicectomy. An example of otomy is a sternotomy, cutting into the sternum to access the thorax. And plasty is a term we use for reforming or reshaping something. And that can be anything from a vessel, for example, a balloon angioplasty, and that's we're reshaping it because we're busting the lumen back open. But it could also be something like a rhinoplasty or a nose job. Okay. So some classic stoma terms. I thought we'd just break down the sort of the namology. There must be a better word for that, but I don't know it. Colostomy is colon and make a hole in it. An ileostomy is the ileum and make a hole in it. So they're actually quite simple. And you can see here in the diagrams on the right some examples of both of them, which actually we'll deal with just next. So that's a colostomy on the top there and an ileostomy on the bottom. So if we're thinking about stomas, we're thinking about, well, if we're thinking in terms of the sort of classical ileostomy, colostomy sort of stomas, we are taking a hollow internal organ and we're bringing it out to the surface, which means you need to traverse the layers of the abdominal wall in order to do that. And this is it's a classic surgical question. It comes up in more or less any surgical exam you're ever going to do. So it's worth really focusing on it and getting it into your head. So if we start from the skin and work our way internally, on the exterior surface, you have Camper's fatty layer of fascia. And then beneath that, you have the tougher Scarpa's fascia. Okay. And if you move inside, you've got your external obliques, hands on pockets. And then you have your internal obliques going upwards this way, hands on chest. Then you have your transverse abdominis muscle going straight across. And finally, inside that, you have the pre-peritoneal fat before you then get the parietal layer of the peritoneum. And remember, the visceral peritoneum is closely adhered to the surface of the organs. Our diagram on the right here is just sort of showing the breakdown of the planes as you dissect downwards. Now, some common abdominal incisions, okay? So they are labeled 1 to 10 here. And I think it's good if we just spend a little second going through what each of the incisions is for. So number 1 is Koch's incision, and you can see that's sort of, it's just below the right costal margin, and because of that, it's going to give us excellent access to the liver. So lots of more minor open liver surgeries, particularly it's the right lobe of the liver. If you're looking to access the left lobe, it comes quite far over to the midline, and then you'd actually be looking at more like something like a rooftop incision or Gabel's incision. And that's classically used in liver transplant, where you need really good access to the large vessels and to the liver itself. And you can also do a cool thing called a Mercedes-Benz extension, which is when you go straight up from the top of the Gable incision. Number 2, that's a thoracoabdominal incision, and that is classically classically be on the right side, actually, in order to access the esophagus, the mediastinal portion of the esophagus during an esophagectomy. 3 is your midline incision. That's your classical general surgery incision, really. Gives you very good access to the bowel and many other viscera. Number 4, Rutherford-Morrison. That gives you nice access to the external iliac vessels, which is very useful for during renal transplantation, where you anastomose the transplanted kidney to the external iliac vessels. Van and Still incision is going to be your classical incision for a cesarean section. And number 7 there is Lands. Number 8, McBurney's. 10, number 9 is a paramedian incision. It's not really done so much anymore. It causes more bleeding. And number 10 is a McEvedy, and that is what you use for femoral hernias in order to reduce them. Great, so just reminding everyone of our abdominal anatomy, and you can see there that effectively where you make an incision is in order to access the underlying organ there. And so just reminding everyone of where our abdominal viscerae are, and that's very useful for when we're thinking about siting a stoma. So depending on what part of, say, the colon needs to be brought out, you can think about where the stoma is going to be positioned. But there are some classical places for stomas to be positioned, and we will discuss those now. So probably the most common type of stoma actually is an end colostomy, okay? And this is when the colon is brought out to the surface, and a rectal stump is left in situ, which is sutured back together. So colostomies are relatively flush to the skin. They will stick out a little bit, but much less so than an ileostomy, which is quite obviously spouted. They are, because of the types of operation that are done, and because normally you'd only form an end colostomy when you're removing part of the left colon because the blood supply is not as good, it means that you normally find an end colostomy in the left iliac fossa. If you're resecting the right-hand side of the bowel, unless the conditions are very unfavorable, for example, in nasty fecal peritonitis from diverticulitis, you can generally anastomose the small bowel to the distal segment of where you've resected. So end colostomies will produce more solid contents than ileostomies, and patients tend to have more properly formed bowel motions, certainly compared to ileostomies. Now, an end ileostomy is where the ileum is brought out, and that represents the most distal point of the bowel from there onwards. So ileostomies are spouted, and that's because the enzymatic content and the pH of an ileostomy is much higher. And you can actually see in this ileostomy in the image here that there is a bit of irritation of the skin around the site of the stoma formation. So because of simply where the ileum is anatomically, they're much more commonly in the right iliac fossa, but they produce much more liquid content, and they are harder to manage, and they are higher output, and patients have to be more careful about their hydration status, and that's something that we'll sort of deal with a little bit later as well. So another type of ileostomy is a diversion ileostomy. And it looks exactly the same, except it will be seen with a further stoma. And this is because the diversion ileostomy is performed it's either to rest an anastomosed bowel segment of a delicate anastomosis, or it might be because, for example, in ulcerative colitis, there is a lot of inflammation in the colon. And as a method of trying to preserve the colon, what surgeons can do is bring out a diversion ileostomy and rest that segment of bowel until it has recovered a bit more, and the patient can be started on sort of more stable medical therapies and optimized before any further surgeries. This is another type of stoma, a urostomy, and that's when the ureters are brought out to the abdominal wall. And that's usually because of something like bladder cancer, where the ureters are not affected, and therefore the ureters can be brought out to the abdominal wall and the bladder removed. So, but I mean, just because of the size of the ureters, these stomas are going to be a lot smaller, and obviously they're going to have urine in the bag. Yes, if the ureters are not long enough, then we may need what's called an ileal conduit, where some of the ileum is resected, and it is used to fashion a segment that can then be anastomosed to the ureters and brought out to the skin. Now, another type of stoma is a mucous fistula, and this is seen just below the end colostomy in the diagram here. So your end colostomy is passing all of the bowel contents into the bag, and the mucous fistula is there as a sort of way of venting mucus, and it can prevent this thing called a rectal stump blowout. Now, you can imagine in the rectal stump, when it's closed off normally, that's fine as long as there's no inflammation there. But if there is inflammation, then the segment of bowel doesn't have the same kind of drainage effectively as it once would, and the same amount of normal peristalsis. So it can build up, and you can get this nasty thing called a rectal stump blowout. And therefore, if there's lots of inflammation, mucous fistula is quite often indicated, and you'll see a few of those. And it can be quite confusing because you have two things in the left lower quadrant or the left iliac fossa, and it's difficult to know how to interpret. But don't be caught out by that one in a sort of OSCE scenario. And then we've got two different things, a loop colostomy or a double-barreled colostomy. I'm sorry, I should say that this could be a colostomy or an ileostomy, but what it means is a loop colostomy is when an incision is made in sort of like half of the bowel wall, and the two bowel segments are not completely separated. The two segments joined together, as you can see here, are then anastomosed to the abdominal wall. And why this is done is because it makes it a lot easier to reverse the stoma at operation. So generally it's indicated, and we think that the stoma is going to be quite temporary, and that we want to sort of reduce the operative load of the patient. It's a much smaller operation, can be done through the small stoma incision. A double-barreled colostomy or ileostomy is when the bowel is completely separated and then the two ends are brought out together and sutured to the skin separately. So in both cases, you get a double lumen, but in the loop colostomy, there will be a sort of shared wall, as it were. So that's another thing that you can be caught out with. And there's such thing as a loop / double-barreled ileocolostomy, where you bring out the ileum in order to divert bowel contents and potentially rest a downstream anastomosis or the downstream bowel, and then you have the colostomy brought out to the surface right next to it. So that is such a thing as well. Now, indications for stoma formation, the main ones really are malignancy and bowel obstruction, to rest bowel anastomosis when there's a lot of intra-abdominal inflammation and it would threaten the anastomosis or threaten any attempted anastomosis. So generally that's when you bring the bowel out. But other things such as IBD, now Crohn's, we try desperately not to touch the abdomen of someone with Crohn's, because they're so pro-inflammatory that it causes terrible damage. But unfortunately, sometimes there's no way and it has to be done. Ulcerative colitis, if someone's bleeding out, the definitive management is going to be a subtotal colectomy. And so for ulcerative colitis, there are quite a few surgical indications, and something like a diversion ileostomy can be really, it can revolutionize some people's lives, because they have such bad bowel inflammation, so much bleeding, that it's the only way to allow the colon to recover. And I've seen this myself on the ward, and it is amazing the effect it can have. Other more minor indications for stoma formation can be things like incontinence and genetic defects. So on to examination of stomas, and I've included this section because it's something that I just had absolutely no idea how to do in final year, and it's actually really easy, and it's quite a thoughtful thing in a way. Like people will ignore doing this stoma exam, and it's just not very thorough. It's not hard to do, and it doesn't take long. So hopefully after we go through this, you guys will all feel much more confident examining stomas, knowing sort of how to interpret things that you might see. So your first step is always going to be performing the normal examination. And if you see a stoma when you're talking through this exam, be it in your OSCE scenario, be it whatever, just note that the stoma is there and note where it is, because it's most likely that the stoma is over whatever structure is being brought out. So, you know, if it's in the right iliac fossa, it's likely to be ileum. The next thing to do is consent. Because remember, patients may be very self-conscious about their stoma, and it's a very personal thing. So please maintain dignity, gain consent for the exam before you start to look at the stoma more closely. Now, normally, the bag that's on this image here is not a terribly good representation, because normally the bags are skin colored, and you have to pull back a sort of skin-colored flap in order to look into the bag to see what's called the effluent, or the fecal contents. Now, the bag is designed to hide the effluent, and if you've never examined a stoma before, it's going to be really obvious, because you're not going to know how to examine the bag. So get some gloves, and I really encourage you after this talk to go out and try and find some stomas on the ward and ask patients if they wouldn't mind you examining them. And then you can look for some of these things. So Stoma bags, as I was saying, they're often skin colored. They need the flap to be lifted in order to see them. And you have this pad, which you can cut to size and stick down over the stoma. Now, it's important that the sticky pad is fitted properly. Otherwise, you get things like leak from the stoma, which patients find incredibly distressing, as you can imagine, and it can be quite embarrassing as well. Cut to size, and in order to remove a stoma, if that ever comes up, if you ever get asked to do that in an OSCE, which I actually was at medical school, there is a special spray, and it's like a cool spray, and it just lets the sticky pad there come off really easily. So you can look extra swish if you're in your OSCE and you say, and if I was to examine the stoma properly, I would like to remove the stoma with the spray that I can see here on the bedside, etc., etc. Step number 4 is looking at the stoma itself. So at the bottom here, we've got a nice, healthy, spouted ileostomy with a bit of contents, with a bit of effluent just in the lumen there. And then above it, we've got some not quite so healthy looking stomas. So the one on the left at the top there, that is what we'd call dusky. That's the correct descriptive term. And you can see it's a bit patchy. It doesn't look nice and red and pink, healthy and moist. It looks a bit dry and a bit dark. And that is a bad sign. And that is a sign of ischemia. And even more of a sign of ischemia is the one on the right. So you can see that's actually a double-barreled, probably colostomy. And you can see one lumen there and the second lumen, and that's a necrotic-looking stoma, and that's a bad sign indeed. So things we're looking for, as I sort of alluded to, are the color of the stoma and the consistency of the bowel in there. You know, bowel is a living tissue. It should be moist, pink, and well perfused. We all know how good the blood supply is to the bowel because of the need for absorption. And so it should be reflected in the bowel itself. You want to make sure if you have an ileostomy that it's spouted, and when you're looking at the stoma, it's very good to comment on whether or not it is spouted. And then you want to comment on the quality of the effluent. So is it runny? Is it particularly offensive? What the color is like? Checking with the patient how different it is to their normal effluent. And then it's really nice touch if during your examination you can just check the surrounding skin, because not all patients care for their stomas in the best way, and they may have some sort of surrounding irritative dermatitis, and it's great if you can just pick up on any signs like that. And then finally, you just don't need to complete the exam, so that's thanking the patient. I always recommend, as a top tip in OSCEs, offering to help the patient get dressed. It just shows a real kind of humility, and summarizing the findings to the examiner. And then you do your sort of A-star stuff, explain their extra tests and investigations, why you want to get those. So back to our case with our 75-year-old gentleman, and now that we know he has a stoma and he's got these electrolyte abnormalities. So on your examination, his abdomen is soft and non-tender. He's very dehydrated, actually. He's got quite sunken skin and dry mucous membranes. He's got a stoma in the left iliac fossa, and it's pink, moist, and very healthy. However, it contains yellow liquid feces, and he admits to you, he's already had to change the bag 3 times today, which is definitely not normal for him. But there's no blood in there, and he's had this bit of extra skin redness while he's had this extra discharge from his stoma. So what do you guys think the diagnosis is? And we'll go back to our presentation. Yeah, so not just what's the diagnosis, but this is a bit of a 2-step question. So what's actually the most likely cause of the presentation? So you need to get the diagnosis and then you need to think about what's causing that pathology. Just give you a minute to answer that. Okay, so this is a quite a hard question. I can see people are thinking about it. So I'm going to go ahead and give you the answer, and I'm going to talk through and explain why. So the answer is a Campylobacter jejuni infection, okay? And we'll talk through them a little bit. So this gentleman has a high output stoma, okay? It's one of the known complications of stomas that we're going to go through just now. But something like parastomal cellulitis, that's just basically saying that the skin is a little bit inflamed. It wouldn't give you higher output through the stoma. Short bowel syndrome would give you a high output stoma, but you need to have resection to the degree that you only have like less than a meter of small bowel left in order to get short bowel syndrome. This gentleman's only had a tiny little bit of, he's just had a left hemi. So it's not actually enough to cause short bowel syndrome. So it wouldn't be that. Intra-abdominal sepsis doesn't really fit because he doesn't have an acute abdomen and he's not really unwell enough. Taking codeine for back pain, that would give you the opposite. That would actually increase the thickness of the secretions. And therefore the answer is Campylobacter jejuni infection, because it gives you diarrhea, this sort of crampy abdominal pain, a bit of nausea and vomiting as well. And is one of the reasons that, intra-abdominal infections like gastritis sort of infections are one of the reasons that people with stomas can represent at a later date with high output rather than straight after the operation. Okay, so back to the presentation. So we'll deal with the stomal complications now. And the first one we're talking about is high output stoma, as our gentleman in the case had just there. So you can see that's a very full stoma bag. And remember, stoma bags can become full of gas as well. So you can actually see in this diagram quite now, this is much more like the stoma bags that we have in the NHS. They're skin colored. They are, that you can see the little flap that you have to pull back here in order to get access to this sort of clear plastic window that lets you look in to see the quality of the effluent. High output stomas are going to be most common with ileostomies in general, and they're defined as greater than 1.5 liters a day. Now you can imagine that if we're supposed to drink 2 liters of water a day, just as normal human beings, and then a person with a stoma has an extra 1.5 liters of output, it can be very difficult to replace the fluid losses. And so it's really important to assess the fluid status accurately in these patients. Because of the ileostomy content, because the ileostomy content is so high in electrolytes, the ileal secretions are so high in electrolytes, they get gross electrolyte abnormalities, hyponatremia, dehydration, hypophosphatemia, and that puts these patients particularly at risk of refeeding syndrome as well. So the risk factors for having a high output stoma are short bowel syndrome, any infections of the stomach or bowel, as we were saying in the question, any prokinetic medications that decrease the transit time. and any other kind of sort of bowel inflammation, something like IBD, we're thinking there. The way to treat them is stepwise. You start by fluid restricting, because hypotonic fluids such as water are just going to exacerbate the electrolyte abnormalities, and they won't replace the free water deficit. So you actually need to fluid restrict the patients and then start them on IV fluid replacement and an IV electrolyte rehydration as well. If that's still not enough, then you can get the patient to try some St. Mark's solution, which is basically like a diaurolite or an oral rehydration salt solution that we have in the UK here. It's hypotonic and you drink it orally, and it can help reduce the output from stomas. And it's used in a lot of the centres around London where I work. And then your other options after that are to step up to medications like loperamide and codeine, which are well-known constipating medications and can reduce the gut transit time, can increase gut transit time, which allows greater water reabsorption. Something else that can happen is stoma obstruction, and that will present, as you can see on the right here, with features of small bowel obstruction. So that would be nausea and vomiting, no output through the stoma, no output of gas, pain and distension. Risk factors for that are going to be intra-abdominal conditions. So you've got your IBDs and strictures that might occur in the bowel and then become obstructed, diverticulitis, any volvulus, an incarcerated parastomal hernia, or after any abdominal surgery. And that could actually be an ileus after that. Treatment is going to be conservative measures if it's a partial obstruction. With any bowel obstruction, you're going to start via the drip and suck approach, and then failing that, you're going to be straight onto your surgical management measures. Stomal hernia and stomal dehiscence they have the same risk factors, so they're grouped together here. Stomal hernia itself is the most common long-term complication of having a stoma cited, and there are some schools of thought that actually anyone with a stoma will develop a stomal hernia after long enough, and that's because you effectively create a defect in the bowel wall and you poke bowel through it, which has no tensile strength in itself. So after years of things like a chronic cough, and that's why smoking is a risk factor, or being overweight increases intra-abdominal pressure, increased intra-abdominal pressure over time, which is why age is then a factor as well. They all increase your risk of eventually developing a stomal hernia. And this will generally present with a lump, but if that becomes an irreducible lump, it becomes hard and painful, then you're thinking potentially it's incarcerated, and that's going to be a bowel obstruction. So the measures for treating are, well, broadly conservative, leave it alone if it's not causing any problems, or a surgical repair. After 2018, there's a new school of thinking that perhaps we should be, because of the pathology of stomal hernias and that everyone is very likely to develop them over time, there's a thought that they should be implanted with primary mesh prevention. So you suture a praline mesh to the bowel wall at the time of operation. Stoma retraction. So this is actually the most common reason for reoperation, and occurs normally due to poor surgical technique. So it means that not enough of the bowel was mobilized in order to give like sort of free movement of the bowel when it undergoes its normal peristalsis, which leads to the bowel then becoming retracted inside. But another cause, an important cause, can be bowel ischemia. So it's important to rule out bowel ischemia if you have a retracted stoma that is causing problems. quite often it won't cause any problems, but the issues can be, and the issues I've seen on the ward with it are when a colostomy becomes retracted, the patient becomes constipated, and then there is reduced output through the stoma, and the stoma can become blocked, and that can lead to symptoms of bowel obstruction, as you can see. So investigations with stomas are, I mean, it's not as big a part as some of the other surgical conditions. Obviously, if you're expecting any kind of intra-abdominal pathology, you have an incarcerated peristomal hernia, you know, you're going to need all your standard bloods, you're going to need your CT in order to check that. If you're suspecting ischemic bowel, you can get CT angiograms, etc., etc. But it's mostly going to be clinical acumen with dealing with stomas. So yes, I was saying the key assessment points are going to be your history, the quality of your stoma exam, and the effluent, and then any imaging as necessary. When to escalate to your reg? Well, it's fairly simple with stomas, and it's going to be quite obvious. Either they're not getting anything out through the stoma and they look obstructed, or it's a patient who has a stoma and they're complicated because it's an abdomen that's previously undergone major surgery, and it needs to be looked at promptly by a senior. So I just thought I'd show you how they actually create the stomas, and you can see it's very well illustrated in the diagram here. So they create the defect in the abdominal wall, usually by passing a surgical instrument from the inside of the abdomen out through the abdominal wall, and then creating an incision, pushing the bowel through it, and then suturing to the abdominal wall. So that's how they do it. Okay, great. But sorry, I've actually taken longer than I thought I was going to there. But we will move on to the end of session questions, if that is all right with everyone. So click through to the next one. Great. So we've got, I think we've got 4 questions here just to finish off the session, 4 or 5 questions. And in the first one, I just want to know, based on everything we've talked about, which of these options do you think merits a stoma formation? Sorry, beg your pardon. I'll just give you a minute to answer that as well. Okay, just 10 seconds. Right, that's enough. And the answer is severe bleeding in ulcerative colitis. Okay, so that is a classical reason actually for formation of a stoma. It would usually be a subtotal colectomy, potentially with a mucus fistula and an endoileostomy. The reason the others are incorrect is because uncomplicated diverticulitis is managed with antibiotics. Subacute bowel obstruction is not an emergency and should be managed conservatively. Intra-abdominal abscesses in IBD patients, as we were saying, if at all possible, we want to not touch the abdomen of a patient with Crohn's, and those are the patients that are going to develop these intra-abdominal abscesses, not so much in UC. So for that reason, we manage them generally with a protracted course of antibiotics. And Hirschsprung disease is you perform an anorectal pull-through procedure. Okay, next question. 42-year-old lady presents with lethargy and weakness. She has an ileostomy with a 2-liter daily output. Her sodium is 126 and her EGFR is down at 53. What's the first step in management of this patient? So I'm talking here about the A to E approach. Okay, so we'll go through the answer now. Okay, so that's great. Well done to the majority of you. So the answer is normal saline IV. And that's because we can't replace the losses with oral fluids. St. Mark's solution itself is a hypertonic solution that you take orally, but it's a bit further down the management. It's not there right in our acute resuscitation phase. The hyponatremia is not that severe. 126 isn't that bad, really. So it's not going to be the first thing that we think about replacing, and it, you know, it might be causing some of her symptoms, but that will get better with actually, I mean, the normal saline will correct the hyponatremia as well. So I suppose they're both sort of right. Hold nephrotoxics, yeah, that's true, but it's not going to be the first thing we do right there. And hypertonic saline IV is only indicated for a severe hyponatremia, something like less than 100, 115 or 110. I don't actually know. You'd have to check guidelines for that. But it'd be hypertonic saline orally that generally we're using. So that was a bit of a trick question for that answer. Next one. So a consultant asks you to identify a stoma. The stoma has two bowel lumens which share a wall centrally, and it's located in the left lower quadrant of the abdomen. What type of stoma would we call this? Okay, so well done to the majority of you again. The correct answer there is a loop colostomy because they share that central wall and it's in the left lower quadrant. Double barrel colostomy is close, but unfortunately the bowel has to be completely resected and the two segments of bowel separated to be a double barreled one. Great. A 47-year-old man develops leak from around his long-term colostomy. Which of these options is not a recognized cause of leak? Okay, great. So the answer there is local skin irritation is not a cause of, oh, it's not working. Local skin irritation is not a cause of leak from around the colostomy because it doesn't affect the way the bag sticks to the skin or anything like that. Whereas a poorly fitted bag, stoma retraction, i.e. changing the shape of the stoma site, poor technique where the bag isn't being transfixed properly, and things like stomal hernia where the shape of the orifice can again be distorted, those would all be reasons for leak developing. So we didn't go through that explicitly, but I just wanted to test a sort of bit of lateral thinking based off some of the stuff we've been talking about. Okay, last question now, and this is a tough one. So a 68-year-old lady undergoes an emergency bowel resection and stoma formation. 4 days later, the ileostomy appears dusky. What is the most likely cause? Remember, it's an ileostomy. Okay, I'm just going to give a few seconds more, so get the answers in. Okay. So the answer here is in fact stretching of the bowel when forming a stoma, and that is because stretching the bowel compromises the blood supply to the bowel and therefore leads to it becoming dusky. As we were saying earlier, ischemia is a recognized cause of dusky ileostomy appearance. So an incarcerated parastomal hernia would be the incarcerated part that started becoming dusky. Thrombus affecting the inferior mesenteric artery seems like a good answer, but unfortunately the inferior mesenteric artery doesn't actually supply the ileum. It's the superior mesenteric artery that supplies the small bowel, and the inferior mesenteric artery only supplies from 2/3 the way along the transverse colon. So that's the reason that's not correct. High output stoma, no one's identified. And stomal dehiscence, well, that's just the stoma coming away from the abdominal wall and isn't itself a cause of the stoma becoming dusky. Now, ischemia may cause the stoma to dehisce, but unfortunately it doesn't work the other way around. Cool. So they were quite hard questions actually, and just wanted to really push you guys because it's a shorter session. As ever, our surgical webinars, you can sign up on the website to get links to join every week, and we have started putting articles online so that you have a written source of information to support your learning for the session. Stuff we're working on at the moment, we are trying to improve the webinars however we can, and we're trying to generate a model that we can run with in the future. So we really do want to hear any feedback you have. You get a survey, please. Oh, sorry, the next session is not on gallstone disease. The next session will also not be happening next Monday. It will instead be happening on Tuesday. Do apologize for the inconvenience, and we will change the Facebook settings on the webinar. Please do scan the QR code to get your feedback survey and certificate for attending the session. This session will go onto YouTube, and as ever, any questions, always give us a shout. pleasure to be teaching again, and I hope to see some of you for the next sessions. Thanks very much.